was just
while you're giving him compressions.
While I'm doing compressions, he starts peeing. I'm like, can someone help me?
It would go up his back, and all that bacteria started eating away his skin. And so by the time he was found, the firefighters had to come in and literally like pry him. Like his back had started like merging with the
He
seat.
died that night. She knew. And the thing that like gives me chills still to this day is I went in and I sat with her for a while, and I took my gloves off and I held her hand, and she like literally cried and said that was the first time that someone had done that.
And he said, was she alone? And apparently in their culture, to be alone at death was not a good thing.
Right.
And I said, no, I was here. Like I was here the whole time. And that gave him so much relief that somebody was there. Well, hello all. I am Dr. John, and this is our inaugural podcast for Nurse Stories. So Nurse Stories is just going to be myself and nurses chatting about the old times and all the crazy shenanigans we all went through when we were bedside nurses. So today we have a special guest. This is Samantha Billingsley. Say hi, Samantha.
Hello.
And Samantha and I go way back. I first met you. When did I first meet you?
2013.
You actually did the math?
Yeah.
So 2013, I was working at the hospital, and she was a new nurse. Was that your first nursing job?
Mm-hmm.
Straight out of school?
Straight out of school.
So she was a new nurse, and she had gotten a job at the float pool. And her inaugural run, the way the float pool training worked was you stick it out in a unit for several weeks until you kind of learn the flow of the hospital and the organization. Then you start floating around between the different units. And we were in your inaugural unit.
Yeah. So you had to spend some time on a med surge, some time on a tele, and then the rest of the time on another specific floor. And I think the most time I spent was on your floor.
Yeah. So, but anyways, I got to know her, and I saw her, grow as a nurse. And then when I left the hospital to start my own business in aesthetics, she had just gotten back from Hawaii, and I ended up hiring her as an employee. And it's been great ever since, right?
Yeah, it's been fun.
So anyways, tell us a little bit about your history, about your past and your nursing experiences, and we'll just kind of go from there.
Okay, so graduated from Boise State in 2012. Got my first job 2013 as a float nurse, had a lot of fun, floated between 3 different campuses, all med-surg tele. Also did resource nurse stuff.
Tell us what resource nurse meant.
So resource nurse was you're basically the one nurse for the entire hospital. They call you for things like hard IV sticks, general nursing tasks. They also had you do conscious sedations for endoscopies, help transport patients from the ER to tele floors. That's pretty much just a glimpse of what I did, but it was the best job ever. It was really fun.
It's the best job ever for a nurse because you don't have an ultimate responsibility for a patient.
Yes.
And I don't know about you, but when I was a nurse, that ultimate responsibility of a patient is what really stresses you out.
Definitely. Yeah.
Right?
And you can say no. I mean, if you didn't have time, you could say no. I mean, you were just basically everyone's friend because you were helping everybody, helping these nurses do chart checks and help, take their patients wherever. So it was truly the best. And that's how I met a lot of people at the hospital too.
Yeah, you definitely network a lot in the hospital. Like everybody knows who you are.
Yeah.
And the resource nurse is always, like you said, the best friend.
Yeah.
Because you always treated them so kindly because when you needed them, you needed them.
Yes. Right? Definitely. Yeah.
Right. Were you part of the crisis management team?
No, they came out with that a couple years later. So then they had a resource nurse and then a crisis nurse. So I would help with, starting emergency IVs. If a nurse was kind of unsure of what was going on with their patient, they would call me and it'd be like a second set of eyes. And then we'd kind of formulate a plan. Oh, maybe we should talk to the doctor. Maybe you should check these labs or whatever. And then go from there. So, yeah.
Gotcha. So you were a resource nurse for several years. Then what did you do after that?
We moved to Hawaii and I became pretty much a cardiac nurse. It was more of a step down unit, I'd say, but we also had very, very sick patients on our floor. We didn't have a big ICU. So to me, it felt like coming from the hospital, the original hospital that I worked at, they were just a little more reluctant to take your patient right away. So I got a lot of experience in really sick patients that should have been in ICU but weren't. And so yeah, it was a lot of work. It was hard.
How long were you in Hawaii for?
5 years, and then we moved back.
Do you miss it?
I miss some aspects of it, but not everything. I miss little things, but for the most part, I have such a good work-life balance here. And it's just a better place to live. So, yeah.
100%. And then when you got back into Boise, where'd you end up?
So I went back to the hospital, but I went back part-time, and I went back to a nursing job that was not bedside. So I kind of helped with transporting patients to and from hospitals, connecting providers like in the ER to specialists, things like that. So it was just a different side of nursing, but after 2020, I was pretty burnt out. So I decided not to go
Were you
back.
in Hawaii during the COVID year?
Yes. Yeah.
Oh,
so I left July of 2020. So for a good, 7 months, I was in COVID. It was not the best.
No, let's talk about that real quick because that's really interesting. I was out of the hospital by 2020. I think I left in early 2019 because I did my own business and the hospital at the same time for a couple of years, while I was getting my practice built up. But I have a lot of clients that were nurses during the COVID years, and it was pretty traumatic, like what they had to go through in the hospital, at least the stories they tell me. What was your experience with that?
For me, I think, we didn't know what was going on. And being on an island, our resources are pretty limited. We rely heavily on cargo. So I think that was the hardest part. Honestly, the patients themselves weren't terrible. I didn't feel like I had any traumatizing. I didn't work in the ICU. So my patients that were under COVID precautions, we were just giving them oxygen, their medications. We had a lower ratio with them, so that was kind of nice.
So explain to the audience what a ratio is.
A ratio is how many patients each nurse has. In Hawaii, on the floor that I worked at, I worked night shift. We had anywhere from 4 to 5 patients a night. With COVID, it was more like 2 patients per 1 nurse. Or 3 patients per 1 nurse. It was significantly lower. So because you had to gown up, and it took a long time to gown up in all the precautionary gear. But in reality, I would have 5 patients and one of them would be under some sort of precautions, and it took just as long to gown up. And so, it was just...
Precautions are never fun because, there's different infectious precautions that you have. And gowning up, oh my gosh, I can't tell you how many stories I have of patient needs something, the call lights off. What do you need? I need a glass of water. You gown up, you get in there. And gowning up is like a 30-second to a minute-long process, right? You gown up, you get in there, you give them their drink of water. Anything else you need? No.
Yeah.
You take your gown off, and then what inevitably happens?
They need something else.
5 seconds after you walk out the room. Oh, by the way, I need a pain pill. And you're literally like, oh my gosh, I asked you before I came in, did you need anything? And then you have to do it all over again. And it's so incredibly wasteful because the hospital's paying for gowns and gloves and masks and all sorts of PPE for you.
At the time of COVID, so flu season had just ended, and we had some patients that were getting the flu in the hospital. So somebody in the hospital was giving them the flu. So they were having us change our masks every single time that we would interact with a patient. And in Hawaii, we had 2 patients per room. So even if the patient next door needed something, we had to take off our mask, change it, and then go ask them what they needed. We were changing masks constantly. Well, then COVID hit, and guess what? We didn't have enough masks.
Mm-mm.
So then we would have to reuse our masks. We were reusing our
That's so
masks like
nasty.
each for the entire 3 days that we worked. We had to put our name on it.
Wow.
We would even have to put it in our NPPV those NPPV masks. We would have to put it in a bag, and then they would go and sterilize
Really?
it and then give it back to us.
So they're sterilizing disposable masks.
Yes.
Holy smokes.
Yeah. Yep.
That's crazy. Yeah, and people don't realize what strains we were under during COVID as far as the supply chain. Like all of our stuff comes from China. In my practice during that time, finding disposable gloves was ridiculous. And I was literally at one point paying 40 cents a glove for it. So every time I put gloves on to see a patient, it was 80 cents.
Mm-hmm.
And sometimes you go through 2 or 3 sets of gloves per patient. So I can only imagine what the hospitals were paying, because you'll change your gloves hundreds of times.
Yep.
A shift. Well, at 40 cents a glove, and there's 80 cents, and you do 100 times, that's $800. Or am I doing the math right? No, $80 just in gloves.
Yep.
Plus the mask and everything else. I saw a picture in a third world country during COVID where the latex gloves that we dispose of, or the nitrile gloves that we dispose of, they had lines in everybody's room, and you would wash your hands with the gloves, and then you hang them up in a line to dry.
Oh, wow.
And then when you needed no gloves, you would go to the glove line in everybody's room, and you take a pair down and you reuse them 4, 5, 7, 10 times.
Yeah. That's unheard of, but prior to COVID. That was just a no-no for sure.
No, right?
Yeah.
I'm glad I missed that. There's so much PTSD that happened from nurses from COVID, because the other thing that happened to nurses is forced vaccinations, which a lot of them weren't true. I mean, literally, we have an experimental vaccine, and we're not going to get into that today. But so there was a lot of forced vaccinations. We had a lot of PTSD. The other thing happened was a lot of nurses thought, like, hell no, and they quit, and then we had a huge nursing shortage, which is not saying something, because there's like 4 million nurses in the United States.
Yeah.
But they're like, no, I'm going to quit, and I'll just live off our husband's income right now, or my spouse's income, and then that shortage caused a move for travel nursing.
Yes, it's huge.
Travel nurses made so much money during COVID. Like it was crazy. I have a client who signed contracts for one of the local hospitals for the travel nurses during this time. And I was talking to her about it. She goes, we have so many travel nurses right now in our system. And she goes, it's crazy. I just signed a contract for a rehab nurse. And rehab nurse is I'm not trying to discount their contribution, because they do contribute a lot. But as far as acute patients, a rehab nurse has the least acute patients, right?
Yes.
They'll have multiple patients. They'll have, 8 or 9.
I could tell you my experience as a rehab nurse. They made me float to rehab.
Okay.
It was the worst.
And so, yeah, it's the worst in the amount of things you have to do.
Yes.
But your patients aren't dying.
No.
So you don't have to worry about like killing anybody. So but it's just different types of stressor. But anyways, this nurse, or this person who was signing these contracts, she had signed a contract for a rehab nurse at $275 an hour.
Oh my gosh.
At $275 an hour. Now,
sign me up.
Yeah, exactly. The nurses don't get that whole thing. The agency gets, probably half that, but the nurse is probably pulling in close to $200 an hour, $175 an hour to do rehab.
Yeah.
I'll do that all day long, right?
Mm-hmm.
But anyways, COVID was an interesting time. So, and then you got out of the hospital altogether, and now you're working in aesthetics, right?
Yeah, I love it. Never thought I would do that, and I thank you for that, because I wasn't looking for a job.
Mm-hmm.
And it just kind of fell in my lap and ran with it.
Yeah.
So it's been fun.
It's been a great experience for you, because what you said earlier, freedom.
Yes.
Right? You can make your own schedule. You can do all the sort of fun things that you can do.
Mm-hmm. And you're constantly learning in a different way, and it just makes it so much more fun.
Yeah.
No stress, low stress, I should say. And just learning and having fun.
Perfect. Yeah, you just had a training this week.
Yes.
Yeah.
So, I love it.
Yeah. So you're always learning. There's always some new technique. There's always some doctor with way more knowledge than you, that's learned some new technique in aesthetics or how to, inject lips or biostimulators or new technologies and all that kind of stuff, fun stuff. So
Mhm.
it's definitely keeps your mind sharp.
Definitely.
Well, let's shift gears a little bit. The whole purpose of this is to hear some stories, right? So I want you to tell me a good story. Tell me a story, a crazy story, or a funny story, or a sad story. I don't care. You come up with your crazy story that,
Anything
yeah.
specific?
No,
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 just
just
anything.
anything. Anything that's fun or
Hmm.
controversial or interesting, you know?
Okay, I'll tell you the craziest thing that I had seen. Well, it's not the craziest thing, I should say. It's just kind of like I think back and I'm like, I can't believe that we did that. But we in Hawaii, we worked on a floor that specialized in heart failure. So we had a lot of patients come in with heart failure. Most of the time, they were in their 30s, meth induced heart
Mm.
failure. They only wanted to be in there to get some food and feel better. And then they wanted to go back to homelessness and drugs and live their merry life. So they only came in just
When
to
it was
feel
bad.
better.
When it was
Yeah,
bad.
when it was so bad they couldn't breathe. So we would have limitations on how much they could drink and what they could eat. And we had one patient that came very often, and he got so mad that we were limiting, and he knew this. I mean, he'd been in the hospital so many times, so he knew what was coming and what the restrictions were. And he got so mad. And of course, in Hawaii, they shared a room with another patient. And so he was escalating. We had to eventually bring the cops in.
Mm. Did you have
And
to restrain him?
no, we didn't restrain him, but we ended up paying for an Uber to take him somewhere else. He asked, he wanted to go somewhere else, and he didn't have the means to get there. He
Somewhere
was
else being another hospital?
being another hospital.
Mm.
Yeah. So he was leaving AMA, which is against medical advice. And that was his prerogative. But the issue was, how was he going to get there? And
And
so,
did the hospital pay for the Uber?
no,
He paid for it himself?
no, the nurses did.
Oh, you got to be kidding me.
Yeah.
To
Yeah.
get him out?
Yeah. I mean, he was causing trouble. I mean, and he was escalating. He was throwing stuff.
Oh,
He
I
was
get it.
trying to close the door. Well, we have another patient in there. So cops came, and cops were like, okay, you gotta, something has to happen. And so, yeah, we did.
So that's interesting. And this is a little unknown thing in medicine that, and I'm going to share a story with you
Yeah.
along the same lines, is that these people get in the system and they don't leave.
Yep.
And they aren't paying their bills. Like that guy
Mm-mm.
didn't have insurance.
No.
Like the hospital's eating this cost. And the hospitals have their hands tied because he's not well enough to go out. Like they can't say, okay, you can leave
Right.
because now it's not practice. But they want him out because a nursing unit like yours is $4,000 or $5,000 a day that is costing the hospital to have that patient in there. But their hands are tied, and so they'll do these crazy things. Like, let's say the patient's mentally incapacitated, they'll go to the state and they'll get a ward assigned to them, a ward of the state. Well, that's like a 3-month process, and then the ward can make medical decisions for them because they can't make their own decisions. And so then once you get a ward, then the ward can help you get Medicaid, let's say, and get some funding. And then once you get Medicaid, then you have some more options and stuff like that. But all the time we'd have these or we'd have these patients come into our hospital and they'd be there for months on end, even though they're perfectly fine. Like medically, that we're doing nothing for them. They just don't have a place to go.
Right.
And because we know if we let them leave the hospital, we can't put them in that dangerous space. So legally they had to babysit these people is the best way to describe it.
Take up a bed that could have gone to someone else.
At $3,000 or $4,000 a day. And they're not getting reimbursed for it. So it becomes a hotel hospital. So anyways, your story reminded me of a story, and I hadn't thought about this for years. We had this gentleman that was homeless, came in, and he had lost his house. His girlfriend broke up with him, and he ended up in all he had was his truck, and he was a bigger guy, like a 500-pound guy. and like literally 500 pounds. And he didn't have anywhere to go, so he just stayed in his truck. Have I told you this story before?
I don't know.
Okay.
I
So,
maybe.
yeah. So he ended up in his truck, and his truck broke down in the middle of nowhere, like off a dirt road. And he just stayed in this truck.
Mm.
And he never got out of the truck. And he had like Mountain Dew and bags of chips. And so for 3 days, he's sitting in his truck eating Mountain Dew and potato chips, waiting for somebody to drive by because he was literally in the middle of nowhere. Well, he never even got out to go to the bathroom. And he would just poop and pee on himself. And it would go up his back, and all that bacteria started eating away his skin. And so by the time he was found, the firefighters had to come in and literally like pry him, like his back had started like merging with the seat cushion, which is nasty, right?
That's gross. Yeah.
It's gross.
Yeah.
So they brought him in, and he was so big that we couldn't even we have special beds for patients that have wounds everywhere that literally it's like they lay on sand, and air flies through the sand, and it gives them like this cushion, and then the wounds can weep into the sand, and it'll go through the sand and into a collection container underneath the bed. Well, he was too big that we didn't even have a bed that we could that bed wouldn't that the sand wouldn't support him. So we ended up getting him into some other types of bed. But anyways, he got stuck there for a while, and he's like, we're like, hey, do you have any family? And he's like, no, I don't have any family, except for in Phoenix. I have family in Phoenix. And we're like, okay, well, the case managers were like, okay, well, let's get you to Phoenix, right?
Yeah.
And we got him stabilized. I don't know, a couple weeks of being stabilized. And when you have a patient like that that's larger and can't take care of themselves, it's a lot of work.
Yes.
Because every time they go to the bathroom, you have to get them up. Well, that's a 20-minute process. Every time they poop, you got to get them up. Every time they need food, you got to reposition them. You're turning them. It's just a lot of like manual labor with these kind of patients. So, anyways, the day came. The nurses, similar to what you did, the case managers got a bus ticket bought from Boise to Phoenix, and he literally said, "I don't have it. My home in Phoenix. That person I was going to go see said I can't come." And we're like, oh, no, now what? Right? Because now we have to get a ward. We have to go through the whole legal process.
Yeah.
And then he made the comment, maybe I should just go to Phoenix. I'll just go to the next hospital. And so we're like, okay. I know it sounds horrible, right?
Right.
But we got him on the bus. He got to Phoenix. I have no idea what happened to him after that. But he probably went to the next hospital and got checked in and got a bed and became their problem.
Yeah.
So sad.
It happens more often than we think, I'm sure.
It happened every day in our hospital. I mean, not every day, but frequently through the years. I mean, the poor case managers, and case managing is its whole specialty in nursing.
Right.
Like the amount of effort it takes to, get the hospital paid, get insurance for patients, help them through the stuff that's not in the hospital, but, getting out of the hospital back into the real world.
Yeah.
So what about a funny story? You got a funny story?
Oh, goodness. I don't know. I'll have to think about that one.
All right. What about
Funny.
a sad story?
Oh, goodness.
Lots of sad stories.
Yeah. Just the floor that I worked on, we just saw a lot of death. A lot of death. I definitely became jaded from that one. Yeah, just constant codes. But the one that I think hit me the most, I was a charge nurse that night. One of my nurses had a patient that was kind of calling a lot. So I went in there to see how she was doing. She was elderly, but not, not too old. She was completely with it. She was hooked up to antibiotics, and she's like, I think I'm ready to die. I would really like to be, I want this to go away. The IVs and all of that,
beeps.
the antibiotics. She was constantly on antibiotics. And when you're getting all this fluid, you have to pee so much. And, she just felt limited. And I think this was at the start of COVID. It was at the start of COVID. I'm not exactly sure what month, but so I called, I told the nurse I was helping her. She had, I'm sure, a lot of patients. So We called the on-call doctor. And so on-call hospitalists, they don't know these patients. They get a report and they're just supposed to help throughout the night. And so this hospitalist is like, okay, I mean, I'll come and see the patient. Basically, the patient wanted to be on comfort care. She said, I'm ready to die. She didn't look like she was going to die at all. So the hospitalist comes up, talks with the patient, makes sure the patient's okay, and with it, and can make these decisions. She called the patient's son and explained, the patient wants to get off antibiotics, just wants comfort care at this time. And this all happened just in the middle of the night. And then I go in and we get everything unhooked. She gets some pain medicine, and basically she dies that night.
Really?
She died that night.
So she went from complete with it to death.
Yeah. She died that night. She knew. And the thing that gives me chills still to this day is I went in and I sat with her for a while, and I took my gloves off and I held her hand, and she literally cried and said that was the first time that someone had done that. And she hadn't had touch. And I don't know where her son was, but he didn't come in. He was probably in another state, which is very common for Hawaii. And I was the only one that sat with her and held her hand.
Were you there when
hand
she
to
passed?
hand. No.
Was anybody in there when she passed?
I don't think so. I think they just came in and she had passed. But yeah, that really got me.
Oh, watching somebody pass is the most, I don't know, I always found it an honor that they included me in that process.
Mm-hmm.
I'm not going to dwell on it too much because it'll bring some, I'll probably end up crying or something because it's very emotional.
It is.
And beautiful at the same time. I had this lovely lady. She was this tiny little thing, maybe 90 pounds. I think she was from somewhere. She was a recent immigrant from somewhere in Asia, and I can't remember exactly what country she had come from, but she didn't speak a lick of English. She had a family here, and she was passing. And typically when a patient's passing, you see it coming. There's steps. It doesn't happen like your story.
Right.
No, I mean usually their eyes close, and then their breathing gets irregular, and then the breathing gets farther and farther apart. You got it, right? Kussmaul breathing and all this kind of things, right? And so we were in that process, and I was on the phone with the family and letting them know, hey, probably tonight. And they're like, can you just have somebody in there? And I was the charge nurse, and I was like, yeah, 100%. So, it's 2 in the morning. There's not a whole lot going on. Most of the patients are sleeping, but I just stayed in there with her. And you talk to her, and she didn't understand a lick of English, but you give them permission to go.
Yeah.
And I watched her go, and I literally, when nurses, we're legally obligated, we're legally allowed to proclaim somebody dead. It takes 2 of us. We go in, and how do you proclaim somebody dead? You listen for the heart rate, right?
Mm-hmm.
So as soon as you don't hear a heartbeat, somebody is dead. And so she was passing, and I listened to her heart. I just had my stethoscope on there, and I probably listened for 5-10 minutes. Just the beats just get a little bit farther apart, and then she has a couple beats a minute. Usually it's 70, and then to 1 beat a minute, and then they go. And it's very humbling.
Mm-hmm.
It's very humbling. And so anyways, the family came, and they had brought death clothes. In their culture, they wanted and so we had the honor of changing her and getting her their death clothes. By the time the family got there, she was dressed in her cultural garb, and her son, and I remember it like it was yesterday. He was very, or maybe it was her grandson. It was her grandson. He was very emotional, and he said, was she alone? And apparently in their culture, to be alone at death was not a good thing.
Right.
And I said, no, I was here. I was here the whole time. And that gave him so much relief that somebody was there, that was comforting and whatnot. And so it was a very beautiful experience, completely humbling.
Oh, yeah.
But I never found more honor in nursing than
Helping someone
Mhm,
pass. Yeah, I agree. I
mhm,
think I'll always remember at least her, I mean, I've seen a lot of death, but there was something special about her, especially
mhm.
knowing she just knew, that she was going to die and she just wanted to die peacefully.
Yeah.
So it was pretty amazing.
The
But
the I always had the saying like like human beings, it's really hard for a person to die. Like your body will fight till the end.
yeah,
Like it will go through amazing things to stay alive. But once the mind decides it's done, they're done.
yeah,
Like like as soon as the patient's like, as soon as you like, I can't tell you how many times a nurse, like I will tell it like a new nurse, hey, go give them permission to pass. Like they're on comfort cares, they're
yeah,
passing, and the nurse will go in and say, you know what, it's Susie or Henry, it's okay to go. Your families loves you. It's okay to go, and within hours they'll be gone.
yeah.
Because they hold on. They just want
Hmm.
to hold on. But it's pretty interesting.
Yeah. I think I've seen that too, where families are fighting too much
Hmm.
to keep their family
Hmm.
member alive, and it's almost detrimental to
To
not
the
only
process.
the family but to the patient. And just I've seen that too, and that's really
It
hard.
is hard. Well, here's an interesting statistic. Me and my statistics. Uh, I heard this statistic once. I don't know if it's still up to date, but in the Medicaid system, and Medicaid is typically reserved for poor people, 1/3 of all Medicaid diet dollars, 1/3 are spent in the last month of a patient's life.
Hmm.
So it's literally used. 1/3 of Medicaid is literally used just to prolong it a little bit longer because they usually end up in the hospital, and hospital's expensive, and
Right.
and um, and so I think culturally here in the United States we don't have a good process for death. Like we want to avoid it at all costs, obviously,
Yes.
but we value life so much that we'll do anything to keep it going.
Hmm.
You know, so that might versus other cultures in the world are very accepting of death,
Right.
right? Like they have a process, and when they see it coming, they come home to the family and they're on hospice, and they do wonderful things for them. So, but yeah, death is a part of nursing, especially when you're in the hospital. You see a lot of it,
A lot.
unfortunately.
Yes.
So,
Yeah.
but do you have any crazy stories about the hospital that you and I worked at together?
mm, let's see. I'm sure I do. I mean, I just know that when I worked there, I had just amazing experiences in general with the nurses and the skills I got to do. There was some pretty crazy things that I had to be involved with, as far as like endoscopies or intubating patients downstairs in the ER, seeing codes and whatnot. But I think just,
You ever done CPR?
oh yeah, all the time. I remember one time I was super pregnant. I gave birth a few days later, and a patient coded, and we ran into the room, and I'm just looking at this other nurse, and we're on either side of the bed, and I am so pregnant, and I was just begging her with my mind, can you please do this?
Do compressions?
Do compressions, because I will probably go into labor. And we just kind of like had this eye contact, and she just got on the chest, and we got through the code. But I just remember it was literally like 3 or 4 days before I gave birth. So I'm
Wow.
so glad that I didn't have to do compressions
Yeah.
that night. But I remember one time I was doing compressions on this man, and the hospital gowns are so thin
Hmm.
and barely there. Well, it came off, and all of a sudden he started peeing on me. And I was just,
While you're giving him
while
compressions?
I'm doing compressions, he starts peeing. I'm like, can someone help
Point that in the
me?
right direction.
And so they just put the gown over him, and I just kept going, doing compressions, and he went off to ICU. And then about a week later, he came back to our floor, and I just thought in my head, I wonder if he remembers. He doesn't. He was dead. But I just think, oh, this is the guy that peed on me, and he's back on my floor.
Body of fluids. So
Yeah.
let's go into the segment I like to call which fluid bothers you the most.
Oh, gosh.
So most nurses will say, I'll let Sam answer, but I'll tell you what most nurses will say. So what body fluid bothers you the most?
I would think C. diff, but no.
So C. diff is diarrhea out of control. And when I say out of control,
it smells so
it
bad.
is out of control. And the stink, it ain't good.
No. I mean, one thing, variceal hemorrhages, those are really gross.
So GI bleed type of a thing.
The smell of blood clots coming out of your mouth is disgusting. But I'd have to say the smell of, let's see, skin stuff.
Like burning flesh?
Yeast. Yeasty smell.
Rotten skin.
Infection of the skin.
Especially in the perineum.
Yeah. I remember in nursing school, the very first clinicals we did was at a nursing home. And one of my best friends was with me, and she almost fainted. We were in this very warm room, and the panis had a lot of yeast, and just the combination of everything, she about fell and fainted. And I think that is probably surprisingly a smell I really can't handle.
It's pretty nasty.
Yeah.
Most nurses can't stand sputum.
Oh, that's true too.
Like
yeah.
Cocking up stuff.
We had to take care of some
trachs.
Me.
Yeah.
And
it would never bother me, but
I for sure could not be a respiratory therapist. The mucus and the trachs, I don't like.
For me, the smells that would set me off was always the poo smells.
Yeah.
Oh gosh, they're awful. And I can't tell you how many times I gag. I would literally put a mask on just so the patient wouldn't see me gag when I dealt with them.
Yeah.
Right?
Yeah.
You ever do that?
Oh yeah.
Or you take a mask, you put stuff inside of it, right?
So like, we had these incense or something for throwing up, like nausea.
Oh,
it must be like orange
the lilac.
Something oil, right? Like that. It was some sort of oils, and I would smear that on the mask and then put another mask on, and that would really help. But there's some pretty, I had one patient, he was homeless. He had a foot wound, and he was in DKA, so he was on an insulin drip. He had like MRSA precautions. I'm pretty sure he even had like C. diff precautions. I'm not sure. I know I had to gown up with him. He was in his own room because of that. He had this foot wound, and it had maggots in it.
Ugh.
And they left it because
maggots
are good. But he came in with his foot like twisted and maggots in it. And there was a big ordeal about getting it amputated, and it was just really bad. But he was probably the worst patient I've ever had.
Really? In
my life, for sure. Yeah, he was not good. He would make comments, and he would spit. And I remember one time, you're all gowned up, you're in there. He was on an insulin drip. He had to get blood sugar checks every 2 hours. He had to get lab draws every hour.
It's exhausting.
It was a lot. And I remember before I got ungowned, just like we talked about earlier, I said, do you need anything else before I leave? And he just doesn't even say anything to me, and he just starts peeing. And his urinal is like right there, and he just pees all over the floor. And I was like, are you kidding me?
And he knew that you'd have to come in and clean him up, right? Yeah. Just a jackass thing to do. Was he with it?
Oh, yeah. He was with it. And he just didn't care. He just started peeing. And I remember my charge nurse that night, she's one of my really good friends, and she came in and was like, that was uncalled for. She was ripping him a new one. And I'm glad, because there's so many times where you can't say what you want to say.
You never can say what you want to say.
And, that's something that could have been, I could have helped him. I asked him, and he peed right in front of me. So, yeah, I thank her for that.
Yeah.
Yeah.
Well, before we go into our next segment, I want to give a shout out to our sponsors. Our sponsors of the Nurse Stories podcast is 5 Square Aesthetics. 5 Square Aesthetics helps you as a nurse get into aesthetics. They'll get you everything you need, from finding a medical director to getting you discounted supplies to start your own injectable practice, social media support, legal support, education, everything you need, 5 Square Aesthetics has for you. So if you've ever been interested in a side hustle in the aesthetics and you're a registered nurse, reach out to 5square.com, 5squareaesthetics.com, and they will help you get where you want to go. So thanks again to our sponsor for that. But our next segment is the up the butt stories. Every nurse has a patient came in with something stuck up the yoo-hoo. Do you have any of those?
Not terribly. No. The only times I ever helped out in endoscopy was literally around Thanksgiving, when people eat too much and they get chicken stuck in their throat, or turkey. So I don't, but I mean, I've had some very naughty patients do some things.
Like what?
Like have sex in their hospital bed. And in Hawaii, you share a room with another patient.
Oh no! So they're having sex, and there's another patient in the room.
Oh yeah.
Oh my
big
goodness.
time. Yeah, and just inappropriate things that they'll do, like their tele monitor, their heart monitor will start going crazy, and you're like, "What's going on?" And you go into the room, and they're playing with themselves, having some fun. So that happened a lot.
Yeah. And the patients are going to realize, like, if your heart starts doing something weird, we're on it.
Yeah.
I mean, and if you're taking care of yourself, heart rate might go up a little bit. You might get a little tachycardic there, right?
Yes. Yeah.
I had a patient once, and we would actually, like, they would, be in there for months. They need to have sex. Like, okay, you can have sex. And they'd let us know. We put a sign on the door or something like that. But I had this young kid once, and his girlfriend came over, and they were in there and they were having some fun, but we didn't even know about it. But I went in, and you have to assess these patients every 4, 6, whatever, however many hours. And so I opened up his gown to listen to his heart, and there's drawings all over him. And they had played this game where they would draw on each other's skin, and they drew all the way down, and even on the wiener.
Wow.
And I'm like, well, it looks like you had a little bit of fun. He's like, yeah, it'd be funner if I wasn't in the hospital, type of a thing. But sex is important. Like, people have sex in the hospital all the time.
I remember at the first hospital that we worked at together, they allowed beer. Mm-hmm. They would write orders for beer for withdrawal. And I never saw that at the hospital I worked at in Hawaii. And that's important too. I mean, if you're not in there for alcohol withdrawal, then why not?
Yeah.
To keep you from going into alcohol 100%. Withdrawal.
When those orders came through, the hospital doesn't have beer on stock. We'd have to go to the convenience store across and buy it, and then the hospital would reimburse us for it.
That's amazing.
So, dietary, the dietary people would go get a 6-pack,
right,
and let them have a beer.
Yeah.
And so, but yeah, I mean, if you're not there for alcohol withdrawal and you drink beer all the time, then doctors definitely didn't want to have to deal with that.
No.
So they're like, okay, you're going to drink a beer or 2 a day.
Right.
Keep you out of withdrawing, because withdrawing from alcohol is
awful.
not a fun thing.
And you can die from that.
Oh, yeah.
And so, yeah, that's, especially if you go into really bad alcohol withdrawal, you have to be on a drip, and it's,
yeah, so they put
ICU.
they'll put, for those of you who are listening who aren't nurses, they'll put you on a drip of like Ativan or some benzo, like a Valium type of a drug, depending on what kind of withdrawal they were going through. In the amount of medication we would give these people, it would just kill the average person.
Oh, yeah.
And it doesn't even touch them.
Yep.
Because they drink so much alcohol. It's the same biochemical pathway. And so you'd be in there. Like I had a patient once, I was in there every 15 minutes pushing 2 milligrams of Ativan.
Yep.
And they're withdrawing so bad. I mean, they're just in the shakes, and you're like trying to keep them out of a seizure. And you're just in there every 15 minutes, push, 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 push. And, on top of that, you've got 4 other patients.
Right. I remember one time in Hawaii, I mean, I had mentioned that our ICUs were pretty small. We had a patient withdrawing, and it was a lot. We were pushing, we had the ICU doctor at the bedside and said, push another one, push another one, push another one, push another one. He would not take him to the ICU. We gave him so much Ativan. We were just literally going to the room, giving it, going back to the
machine,
Omnicell, getting another one, going, pushing it, going back, like so many times. I'm like, this guy needs a drip. I can't do this all night, and so they did finally take him and put him on a drip, but it took a while, and it was beyond crazy to me that we had to push so much and just keep pushing. So
alcohol withdrawal is not a fun thing to experience. It's so time consuming for the nurse.
It really is. Yeah.
It's so time consuming.
That's why they need to be on ICU and be monitored more closely. And
but the hospital's reluctant to get in there because it's going to cost them so much more to keep them in the ICU.
And I'm sure there's other sick patients that
need it more than they do, right?
Yeah.
You only have so many ICU beds. It's like, okay, do we really want to give an ICU bed to somebody who's withdrawing from alcohol versus somebody that like is septic and just had a heart attack and fill in the blanks.
Right.
That really needs the time. So, but yeah, that was always the alcohol withdrawals, which was so many patients.
Yeah.
Like patients who come in for like an appendectomy, and go into withdrawal. Yep. I've seen some crazy withdrawals. You want to hear my favorite withdrawal story?
Yes.
So my favorite withdrawal story was we had this this older Mormon lady, and Mormons don't drink or do drugs or anything like that, but they do prescription medication because if a doctor says it's okay. So she came in, and when they check in, they're usually a family member with them, and they don't give you the whole story because they don't want the family member to hear the whole story. So when you do their intake and you're like, what medications you're on, they leave out all the really bad ones like morphine and MS-Contin and Dilaudid and all these narcotics that they're on at home, and they're taking vast quantities of because they don't want their family member to know about it. Okay. And all their mental health meds. So they don't give you that picture. Then the family member leaves and they never tell you, and then they withdraw. And so we had literally this situation happen where this woman who happened to be in precautions, she was like in MRSA precautions because she had tested positive for MRSA. And she didn't tell us anything. And then she just starts going crazy at like 2 a.m. I mean, literally crazy, ripping shelves off the wall and throwing them at nurses. And so we had to restrain her and give her some Haldol. And so, security's up there. Again, we're in precautions.
Right.
So we're all gowned up, and she's ripping gowns off people, and it took 4 full-grown men to get her pinned down and to chemically restrain her and to, put her to the bed. And then we did a tox panel on her and found out she was on all of these narcotics. And then we started, treating her for it. And then we pulled the narcotic, from the state, and we like, oh my gosh, she's on so many different medications. So I learned from that, like when I took health history, family members out in the hall.
Yes.
Like you're out. Like I got to get the whole story. I never made that mistake again.
Yeah.
Never. But gosh, the crazies. Like when people go crazy, they go crazy. You have the sweetest little old lady.
Oh, and then
become the devil.
Sundown.
Oh, the sundowning. Don't even get me started on sundowning.
I know. Yeah. It's like the gremlins. The sun goes down. Mm-hmm. Yeah. I had a patient once, post-open heart. And with post-open heart, you have all these tubes. You still have pacer wires. You usually have a chest tube. Well, there's standard orders with open hearts, and usually it involves Ambien. Mm-hmm. And I had this one male patient. He was probably in his 60s. He asked for something to help him sleep, so I gave him some Ambien. I go back in to check on him, and he's on all fours on his bed backwards. And I'm just like, what? And he's naked.
Of course.
Of course he's naked, right? And I was just like, oh my gosh, you're going to pull your tube out? Like, you just had open heart surgery. What is going on? It was the Ambien.
Ambien sent him over the edge.
Mm-hmm. Ambien, he had no idea what was going on.
Ambien, a very small percentage of Ambien, people will get the opposite reaction. They'll go from, instead of a sedative state to a hyper, like, crazy state.
Yeah, and he sure did. Pacer wires and chest tube and all.
He turned out okay?
He did. Yeah, he turned out fine, but that was definitely an experience that I didn't want to happen again. So I was very cautious about Ambien after that.
It's so funny. Like, you get burned once, shame on me. Burn me twice. No, that's,
Yeah.
Burn me once, shame on you. Burn me twice, shame on me. Right? You've heard that saying before.
Yes.
Like, you make one mistake, you'll never do that again.
Absolutely.
Like, you'll be like, let's not do some Ambien, right? Even though 95% of people do just fine on it, right?
Yeah.
But yeah, it's pretty potent. Well, we've been chatting for a while. You got any last minute like crazy story?
I don't think so.
Yeah.
I'll have to think about it for next time.
Yeah. Well, we'll do it. We'll do another one of these in the future. So.
Yeah.
Well, anyway, Sam, thanks for joining the podcast, and thanks for all of you for following along and hearing a few crazy stories.